Presentation of To the Best of My Knowledge on WPSU is made possible in part by support from the Penn State Alumni Association, informing, involving, and inspiring Penn State alumni and students through its publications, programs, and events. On the web at alumni.psu.edu. And from the members of WPSU.
From the studios of Penn State Public Broadcasting, this is To the Best of My Knowledge. Good evening, I'm Graham Spanier. Our topic tonight is cutting disorder and other kinds of self-injury. Cutting disorder is far more common than most people realize. An estimated 2 to 3 million Americans engage in some form of self-injury. And while it's most common in young people, it's not just a teenage problem. Why do people cut themselves, and where can they turn for help? We'll answer those questions and take your phone calls at 1-800-543-8242. Or if you'd rather email us your question or comment, our address is response@psu.edu. And now let's meet our guests. Dr. Richard Levine is Professor of Pediatrics and Psychiatry in Penn State's College of Medicine and Chief of the Division of Adolescent Medicine and Eating Disorders at Penn State's Children's Hospital. Also with us is Dr. Candace Good, a psychiatrist with SUNBRIDGE Health in State College, Pennsylvania, an organization of independently practicing mental health professionals. Dr. Good is board certified in general as well as child and adolescent psychiatry. Before relocating to State College, she was an assistant professor of psychiatry at the Western Psychiatric Institute and Clinic at the University of Pittsburgh. Thank you both very much for joining us.
Thank you.
Thank you.
Self-injury is real, of course, and according to clinicians, it's on the rise, especially among young people. But is it an actual psychiatric disorder in terms of the diagnostic manual that the profession recognizes? Dr. Good?
Well, it certainly is an important topic because it is very common. For example, if you look at adolescents who've been admitted to the hospital to an inpatient psychiatry unit, about half of them will endorse that they've been involved with some type of self-injurious behavior. If you actually open the DSM-IV, which is the main guidebook we use in psychiatry to match up a symptom with a diagnosis, it's not necessarily listed as its own disorder. If cutting were the only symptom, we may describe it as an impulse control disorder. It's very commonly seen with depression, anxiety, certain personality disorders, or people with a history of abuse.
Mm-hmm. And Dr. Levine, what is self-injury? What are we talking about here with this phenomenon?
Well, the typical patient would be a teen or a young person who is very anxious, disturbed, upset, feeling overwhelmed with stresses, who then turns to self-harm, cutting and burning and other type of self-injury in order to feel calmer, to feel and to cope with overwhelming emotional problems.
Mm-hmm. Now, I understand that this is most typically a phenomenon between about the ages of 15 and 30. Do you see it much beyond that age range? And, you know, if not, how and when does it pass?
We have seen patients who are older who self-harm, but most patients would be teens and young adults. It's actually more common in females than it is in males, but we have seen males as well.
And I think any of our listeners or viewers would ask the question, why does this happen? What is with individuals who would resort to something like this? Give us some insight.
Well, I think it's particularly confusing for parents and even doctors meeting the patients. They're often in an emergency room setting, and the physician there may not know them or may not even be a psychiatrist. So it can be difficult to tell if this was actually a suicide attempt or, as some people would say, a cry for help.
Mm-hmm. Well, what about suicide? I mean, I think to most people in society, when they see that someone has cut themselves, they would immediately come to the conclusion, oh, this was an attempted suicide. How often would you tie those two together, and can it be something different than suicide? I think I'm hearing you say yes.
Yeah, absolutely. And in fact, now if someone's cut for the first time, it may be more likely that it's a suicide attempt. But the most common means of trying to hurt yourself, as for example, cutting is very common in young females, they're probably more likely to do an overdose attempt or something like that.
So it would certainly be of concern if someone is cutting themselves, and we would assess them for their suicidal thoughts and if they were feeling like they would kill themselves. But most of the young people that we see who cut themselves really are not actively suicidal. They're not actively trying to die. They're really trying to cope in the only way that they can think of to do that. Mm-hmm. And so they harm themselves. They'll often feel that they feel very tense, very anxious before they cut, and then afterwards they start to feel calmer as a way of coping with overwhelming emotion.
Mm-hmm. Very important to look at the pattern of behavior overall.
Wanting someone to know how upset and depressed they are, or to tell a parent or a boyfriend or a girlfriend, I'm in great distress over this situation. When people resort to cutting, is it a cry for help, or is it more their way of simply coping with their life?
I would say both. Mm-hmm. Meaning it is a way of coping with stress and anxiety and depression, a way of exhibiting that. But often the young people are cutting, and they're looking for someone to intervene. So when their family or their parents or the school does notice that, it's very important to then refer for professional treatment.
Mm-hmm.
As a child and adolescent psychiatrist, I mean, I see even more middle school students becoming involved in this type of behavior. And unfortunately, some of them do use it as a way to identify with a peer group, or will also try and draw people in. For example, they'll email a friend that they're about to cut, or instant message someone to let them know that they're in distress.
Does this have some status within certain peer groups?
It can, and there's a lot of literature about cutting on the internet as well. So that there's also a form of almost contagion, is that young people hear about it either through the media or on the internet, and then they try it, and it can become almost addictive, in which that becomes their way of coping, and the behavior becomes self-reinforcing.
Mm-hmm. We don't want to give anybody lessons in this, but where do they cut themselves, and with what?
Most of the patients that we see cut themselves in their arms, on their forearms. They might cut themselves in their legs, and it really can kind of vary, but the forearm is a very common place. And they use really almost any implement that they can find. But again, usually it's superficial. It's not deep to open an artery or something like that.
Uh-huh. Same with your experience?
Yeah, I think in addition, and I think Dr. Levine would agree with this as well, if women have issues about their body, yes, or if there's a history of abuse, they're probably more likely to cut at other sites as well, like their breasts or abdomen, mm-hmm, their thighs. And in addition to cutting, self-injury can also include things like burning oneself with cigarettes, or even I have patients who have done eraser burns, where
right,
they'll just rub their skin repeatedly.
We have seen that as well.
And explain the connection in terms of issues with your body and what you would do because of that. Where's the link there?
Yeah.
Well, for instance, we see a lot of patients with eating disorders, and there's a link between eating disorders and self-harm. So we have had patients cut in the word fat on their body, or cut Anna or Mia, which are terms for anorexia and bulimia nervosa, which are common on the internet, and they've actually carved those words and those letters into their body. Also, as Dr. Gu was saying, if we've had patients who've had trauma or abuse, sexual abuse or rape, they'll often cut their breasts or around their thighs and genitals because of that abuse.
If you're just joining us, I'm Graham Spanier, president of Penn State, and this is To the Best of My Knowledge on WPSU, Penn State Public Broadcasting, and the Pennsylvania Cable Network, PCN. Our topic tonight is cutting disorder, a form of self-mutilation that psychiatrists say is on the rise. Who's doing it, why, and what can you do to help someone who deliberately injures him or herself? We're talking about that with Dr. Richard Levine, Chief of the Division of Adolescent Medicine and Eating Disorders at the Penn State Children's Hospital at the Milton S. Hershey Medical Center, and Dr. Candace Good, a psychiatrist with SUNBRIDGE Help health in State College. If you have questions and would like to ask them of our guests, or if you have a comment that you'd like to share, give us a call at 1-800-543-8242. We'll begin taking your calls in a moment, so go ahead and give us a call. Or if you'd prefer to email us, you can do that at response@psu.edu. So how do patients come to your attention? Are they referrals from hospital emergency rooms? Are they parents looking for help, or is there a self-referral phenomenon as a part of this?
Well, I generally see child and adolescents, so they're usually, brought in by their parents who recently discovered this behavior, or sometimes it can be a behavior that emerges in someone who's already in treatment.
We see referrals from parents and as well as schools who, with the school nurse or the school counselor has noticed the behavior and then referred them in, and also referrals from the emergency rooms and other primary care physicians.
And what would you say is the general level of awareness among physicians, school counselors, mental health professionals out there in the community about this phenomenon? Is it immediately evident to people what's going on and the need to make a referral, or is this one of those conditions that's not really on the radar screen of most family physicians or other professionals working in the health area?
I would say that most physicians are not really on the lookout for this. And the kids can be sometimes quite secretive about their behavior. They'll often say that they have bad cats or something like that, or they scratch themselves. And they don't usually come forward of their own free will. It is very important that if a family physician or a pediatrician sees the behavior, that they recognize its seriousness and then make appropriate referrals. But it doesn't always mean that they're suicidal. They don't have to be admitted to the psychiatric inpatient unit upon discovery.
Mm-hmm.
I think that a lot of people are becoming more aware of it. It's an issue of, do they feel comfortable treating it? There is a real shortage of child and adolescent psychiatrists, so in certain areas of Pennsylvania, it's very difficult, or up to 3 to 6 month wait to see a child psychiatrist. So how to manage that patient in the interim is very, I think, scary for a lot of people. And parents, it's very hard for them to understand this behavior, why someone would intentionally do something that could leave scars. It may be noticeable to other people. Now,
there are other kinds of other types of self-injury, cutting aside just for a moment. Could you describe some of the other things that fall in this general category and that may relate to the same kinds of underlying disorders? I mean, burning,
or hitting themselves very hard with their fist or with an object, or hitting the wall and things like that. I mean, but we're usually seeing what is called minor self-harm, where the injuries are not life-threatening. There are occasionally very psychiatrically ill patients who will severely harm themselves such that they need surgery and such, but that's unusual. Most of these are sort of minor, superficial, but hitting and burning is what I've seen.
I would agree on the burning. We talked about the eraser burn. Some people would even consider excessive piercings as a form of self-mutilation. But
do you agree with that? I mean, that's an interesting concept, because
I might not.
We're seeing
I'm not saying that I necessarily
We're
do.
seeing so much of that now, and you wonder, there may be a point where it crosses a line between just wanting one more tattoo into something that goes beyond that.
I might not agree that piercing or tattooing would be considered self-harm, although I guess it could, in an excessive state, be considered that.
Let me turn to our first question. This one comes via email, and this person asks, is there anything particularly American about this disorder? This is a very interesting question. Is it believed to have always existed, or does it seem to be especially a contemporary phenomenon? So I think what the person's getting at is, how might this tie into other cultures? We see certain problems that are so prevalent in America, and you don't see them much in other cultures. Do you have any sense about this one?
Well, some of the main articles and literature is actually from Italy and Western Europe. So I don't think it's particularly American. It might be rather Western in terms of its prevalence, but not a uniquely American phenomenon, in my experience.
Well, let's turn to our first question from someone who is on the telephones right now. It is Rod calling from State College. Rod, you are on the air. Thanks for joining us on our program. We're going to give you the first question here on the air.
Thank you. I was just calling to see whether or not there was a correlation between what the children do with cutting and burning and what the prison population does in terms of sticking items, metal items, under their skin, through their abdominal walls, into their genitals.
Stay on the line with us, Rod, while we get some reactions to your question.
That's hard for me to answer from my clinical experience because I don't really have a lot of clinical experience with a prison population. My judgment would be that this is different. These are more females than males that we're seeing in clinic. Young teenage girls who are disturbed, depressed, anxious. So I think this is going to be a little different.
Dr. Good, do you see any connection there?
Again, it's not something that I myself have experience with. Again, I think the type of self-mutilation that we're talking about is, I don't want to say exclusively, but maybe primarily female, young teenagers. I don't know in the prison population if that is for some other type of secondary gain. I think the self-mutilation we're referring to has more to do with maladaptive coping.
Rod, let me ask you, is this the prison population something you have experience with? It sounds like you might have a little insight into that side of things.
Not necessarily. I'm a surgeon, and my practice is in Williamsport, but when I was in medical school and have seen it recently, prison population, mainly males, have come to the hospital with items under their skin. They burn themselves too. And I was wondering whether or not there was any correlation with some maladaptive issues with them being in prison.
It's ripe for a study of prison populations. And have you had to do some surgical procedures to repair some of that damage, maybe?
Well, yeah. One in particular that just kind of stands out is I had a patient one time who took an antenna from a television and just bored right through his abdominal wall. And as fate would have it, the prison population is lucky. It split right between the aorta and the vena cava, so he really didn't have any significant damage except through his stomach. But I just thought that was very interesting that he would do that.
Did he give you a reason for?
They never do. They just say, had nothing else to do. And, not asking questions like a psychiatrist at that point. We just need to get them prepped for surgery going in.
Dr. Levine?
I think that's crossing the line from the minor self-harm, which is episodic cutting, burning, etc., to what is called major self-harm, where severe injuries like you're describing that would require surgical correction, amputation of limbs and such. I really don't have clinical experience with that. The prison population might have some unique characteristics, but also it probably does indicate some more severe psychopathology.
Yeah, certainly if somebody would injure themselves to that point, we'd certainly recommend before they're discharged from the hospital that they have some kind of psychiatric evaluation. For example, people who are psychotic can injure themselves without realizing what they're doing, or even if voices tell them to do it.
Our next caller is Rhonda. Rhonda, you're on the air with us now. Thanks for calling us.
Hi.
Hi.
I am wondering about famous people that cut themselves. I know that it's been public knowledge that Princess Di used to do that, and Angelina Jolie. And I'm just wondering what kind of an impact that has on the youth of today. I mean, if they know about it, if they do copycat sorts of things.
I think they do. So I think that you'll find that the young people are very aware of what celebrities are doing, and I think that that's sometimes where they learn about the behavior. They learn about it from magazines, from TV or other media sources, and they hear about it from their friends. So I don't think that they do it just because a celebrity does, but I think that it does have this contagion factor where that if they're upset and they know that a celebrity did it, then they might try it, and then it can become quite almost addictive or habitual behavior.
Dr. Good, have you ever had a patient who specifically referenced a celebrity, or for that matter, even a friend saying, well, I know others do this, so I'm not as abnormal as you think?
I haven't had anyone like reference Angelina Jolie or anything like that. Generally, one of the questions I do ask, though, is how many of your friends cut? And that's sort of a way to use a little bit of displacement, meaning taking the focus away from the patient and asking them more about what their peer group's doing. We'll also do that if we're asking about other risky behaviors like use of drugs, alcohol.
And have you gotten comments back saying, oh yeah, my friends do it?
Absolutely.
Or
Yes.
Absolutely.
do you think it travels in peer groups, so to speak, so that is it somewhat unusual for one person to do it when none of their friends do, versus if they're in a peer group where it's happened before, it might be more common for them?
It would be common in peer groups, although someone starts it, and where they learn about it is probably from some media source, but then it might start a process in a peer group.
Thank you for your call, Rhonda. And next we have Bill calling. Bill, you are on the air with us. Thanks for joining us.
Fine, thank you very much. Always interesting to hear what you have to talk about, and for the best of my knowledge. One of the things that I remember as reading National Geographics is that it appears as though people cut themselves with some positive values, because it appeared in some of these articles that it was done to beautify the body. And I'm thinking maybe people from Africa. So that in that respect, they must know how to do it without actually damaging themselves. And I'm just wondering if it could be any of that that's going on as a means of beautifying themselves rather than always having negative effects. Just want to hear what
interesting comment. I have seen that.
Right.
And
I think this is different. I think that that might relate more to other types of body adornment and body piercing and tattooing, which is prevalent among teenagers and youth. But I think that these are primarily troubled kids. These are kids who have eating disorders or depression or anxiety or might have trauma. And I think that they're not just adorning their body. I think that they're expressing their angst. They're expressing their anxiety, their profound depression, or a cry for help. So I think this is different than body adornment that you might see in National Geographic or any other type of body adornment.
what about socioeconomic status? Would it be correct to say that this is a middle-class phenomenon?
I don't think so. I mean, if I compare my practice now to when I was practicing in Oakland, out in Pittsburgh, the outpatient clinic I was working in there was a lot of what I guess you'd consider lower socioeconomic status, and I think it was just as prevalent as here. I've only been in practice here since August. I think in the inner city type population, it seemed like you had more of the contagion effect, where peer groups engaging in this type of behavior. Again, I can't speak so much about State College yet, but
we've seen all demographic groups and all socioeconomic classes. We've seen really, really wealthy kids. We've seen middle-class kids. We've seen indigent kids. I don't really see a socioeconomic status effect.
How young what, if you think about it, what's the youngest you've seen?
11, 12?
I was going to say maybe 9. I mean, it depends on what type of self-injurious behavior you're describing, because, you know, some kids will have some pretty severe tantrums where they will make threats or scratch at themselves, those types of things. So then you would see it younger.
Even younger. I mean, I've heard it exists at ages 4 or 5.
I think that's a little, I'll defer to you. I think that's a little different, though.
I think that would be not so much what we're talking about as far as self-mutilation. Certainly it's an inappropriate expression of anger or frustration, but I think different than the behavior we're discussing today.
Okay. Frank is calling from State College. You're on the air with us, Frank.
Hi, how you doing?
Very good, thank you.
My question is, does any of you guys have any correlation of brandishing? Like we see athletes out there when they brandish themselves on their arms, college sports, NFL, it's mainly football, I noticed it. Do you think that has any correlation to cutting?
Again, I don't. I think that, I mean, we have seen some teens who have been branded as part of a fraternity or as a team, and I think that goes again to maybe painful, but self-adornment, that they're sort of identifying themselves with a certain group, and I think that's psychologically different than the troubled teens that we see who cut their arms.
Yeah, and again, when we're talking about self-mutilation, that's generally not a one-time thing. It's like an ongoing pattern of behavior, and I think that's what makes it so complex to treat, because if it is if it is a symptom that goes along with depression, anxiety, it will often persist even when the depression gets better.
Here's an email question from Joanne. It says, please speak about the physiological aspect of the cutting experience, if you can. I have read that there is heightened hormonal activity as the body goes into a protection mode, and the result of this can be a soothing feeling at the time of injury. Is this true?
I would agree with that, and that explains the habitual nature of it. The theory is that as the person cuts, that they release what are called endorphins, or endogenous opiates that your body produces for pain and discomfort, and that will produce a calming, relaxing feeling, which is often what the patients describe. They kind of zone out and almost dissociate. And thus it becomes addictive or habitual because they get addicted to that type of feeling, that type of relaxation.
You'd have to have done it once, I suppose, to know what your physiological reaction is and to decide whether it's something that you might want to do again. So I'm surmising that with some of the people that you see, there's a repetition of this behavior.
And I think as people are looking, are there possibly medications that could help treat some self-injurious behaviors? People do start to look at medications that also are helpful for treatment of other addictions like alcoholism.
Our next caller is Melissa. Melissa, thank you for phoning into our program. You have a question for our guests.
I do. The question is, I'm convinced, I'm a psychologist, and I'm convinced that different factors cause cutting and different factors maintain it. If someone is just beginning to cut, it may be a failure of coping behaviors, whereas when they've been cutting for a while, I think it does become addictive. People get used to the sensations, they come to have fewer inhibitions about cutting themselves. So my question really is, do you see a difference between the factors that start cutting and the factors that maintain it?
I would agree pretty much with what you said. I think that it starts off as a coping behavior, and where they learn it is probably from our culture, and then it becomes habitual and repetitive and almost addictive in nature. It's still sometimes a coping mechanism, though. It's how they've learned to cope. They've how they condition themselves to cope with stress, and they do it through this repetitive, habitual manner. But I would agree with you.
Melissa, have you come across this in your practice?
Oh, many, many times, yes.
And by what mechanism do your clients come to you? Again, is referral, family, self-referral?
Sometimes, particularly adolescent clients, will bring it up in the course of treatment for something else. Once they're comfortable, and they say, and by the way, I've been cutting myself. But more often it's parents or school personnel that refer.
It's important to emphasize this is usually for teenagers associated with something else, so that they have depression, they have anxiety disorder, they have an eating disorder, they have a substance abuse disorder. So it doesn't usually pop up in a teenager who is otherwise coping well with life and having no problems. It's usually associated with other type of emotional and psychological problems.
And Melissa, are you still there with us for a minute?
Still here.
When I told folks what the topic of my next program would be, a lot of people were scratching their head like, what is that? And they thought it was something very unusual and very exotic, and maybe even why would we do a show on it? But I'm surmising that among mental health professionals and physicians, it's actually well known and pretty common.
That would be very fair to say, yes.
I mean, I think that in the adolescent population, you're probably looking at maybe between 5 and 10% of adolescents who have at some point harmed themselves. We actually did a study looking at our patients with eating disorders versus a control population, and we certainly saw an increase in patients with particularly bulimia, but 8% of our control population coming to the general pediatric clinic for a checkup had harmed themselves.
Oh, I just thought it was important to add, too, that although we've talked about sort of the progression and the addictive nature of this, it doesn't always signal that there's problems forever. It doesn't always become so overwhelming for certain patients, particularly in adolescence. It can be like an adjustment phenomena, and they're always, as adolescents, growing and developing as far as their coping skills, personality, personal identity. So not all of these patients go on to have, personality disorders or things like that.
Melissa, thanks for your call. If you're just joining us, I'm Graham Spanier, president of Penn State, and this is To the Best of My Knowledge on WPSU, Penn State Public Broadcasting, and PCN, the Pennsylvania Cable Network. Our topic tonight is cutting disorder, a form of self-mutilation that psychiatrists say is on the rise. Who's doing it, why, and what can you do to help someone who deliberately injures himself or herself? We're going to get to that question in a minute. We're talking about that with Dr. Richard Levine, Chief of the Division of Adolescent Medicine and Eating Disorders at Penn State's Children's Hospital at the Milton S. Hershey Medical Center, and Dr. Candace Good, a psychiatrist with SUNBRIDGE Help in State College. It's an organization of independently practicing mental health professionals. If you have questions for our guests or a comment you'd like to share, give us a call at 1-800-543-8242, and you can also email us at response@psu.edu. Next, we've got Bill from Clearfield on the line. Bill, welcome to our program.
My question is, what is the difference between the adults and the children? You're talking more about the children that do the cutting and not a lot about the adults. I know a lot of the adults that do cutting. I work in I'm a consumer myself. I do not do cutting, but I have seen a lot of cutting in the adults. And I go to a drop-in center.
When you say you're a consumer, Bill,
I'm a mental health consumer. I have bipolar and depression and severe stress.
So when you go to a clinic or for a visit, you're aware of some other folks around you who have this problem, and they're adults.
Yes.
Comments on that, Dr. Good?
I think probably we are a little bit focusing on children because those are our specialties, Dr. Levine being an adolescent medicine specialist and myself as a child psychiatrist. I think certainly it is common in adults. I can talk a little bit more about borderline personality disorder. I think part of it, though, is this is a behavior that usually starts in adolescence or young adulthood, and many of the adults are dealing with it, have been dealing with it for many years.
And is there anything about this that's generational, family related? Are you more likely to see it in a child if a parent has it, or is that maybe unconnected?
Certainly mental health disorders can be somewhat inherited. I have not seen a study where self-injurious behavior has been specifically associated with genetics or family environment. I'm trying to remember. I really probably haven't seen, a family where, the mother and the daughter and the aunt and the cut. Where we certainly do see that with patients with depression, with eating disorders. I would agree with Dr. Good. In an adult population, you're going to see more patients who also have borderline personality disorder. You don't usually diagnose a child or a teenager with a full-fledged personality disorder because their personalities are evolving. But you'll see also patients who are depressed and bipolar and eating disorders, substance abuse as well.
I think the importance in adults is that there's often, you help them to find what their identified triggers are, also to help them develop coping skills, and there are a variety of different types of therapy that are trying to help with that.
Let's turn now to Sally, who's on the line with us. Hi, Sally.
Hi.
Do you have a question or a comment for us?
Well, yeah, I actually more of a comment, or just curious about their thoughts about this. I used to work sexual assault and domestic violence, and of course we saw many women who did this. And I want to be careful because I don't want to downplay the problems with this. But over time, I actually came to see cutting, and let me also just say, we worked with, we had women who didn't like swallow Drano and insert needles into their arms and things like that, which clearly can be problematic in terms of their physical bodies. But I actually came to see cutting as sort of the least, I don't even know how to say it, problematic, damaging, in terms of the maladaptive coping mechanisms, as opposed to an eating disorder or self-medicating with alcohol or other drugs.
These are people who had a lot of problems, very, very disturbed, and without minimizing it, in some senses was the least of their problems, given what they were coping with in their lives.
It seemed the most contained way for them to get some relief, in a way that was the least damaging, both to themselves. I think there are clearly ramifications, and I don't want to play that down at all. But I just, as working with people over time, I was just kind of became curious about that.
Well, if you see patients who have significant problems, you talked about severe post-traumatic stress disorder, and who have multiple other psychiatric problems, medical problems, cutting is one of many. And as she said, it might not be the most severe if they have a severe substance abuse disorder or a very, very serious eating disorder, but it's still sort of a maladaptive coping mechanism. It's not a healthy way to cope. And I guess what we would try to do is in treatment is to teach other more adaptive, healthy ways of coping with their problems, so they can get better from the whole host of their difficulties.
Mm-hmm. And Dr. Good, I remember that comment from Melissa about often this disorder is revealed in the course of treating something else. Mm-hmm. Do we then find that this is often tied in with a range of problems that might be associated with adolescence?
Well, for example, if someone enters therapy and starts to talk about past abuse or although they're working through a process in therapy, their stress level and some of the triggers for cutting may increase. And in addition, if you start seeing somebody in the winter and they're always wearing long sleeves, you yourself may not notice. Whereas if somebody comes in the summer, you may see some of the scars and left over, and that's something you're more likely to ask about, obviously. But
our telephone number on the screen is 800-543-8242. Please give us a call and get in the queue. We have someone waiting for us, but I want to turn to an email first, because this individual says, my teenage daughter has seen girls at school who are cutters. She doesn't know any of them personally, but wants to know the best way to help these girls without making their conditions worse. Can you offer any suggestions?
Well, this is something that comes up a lot. Just like teenagers may reveal other things to their friends that they don't necessarily tell their parents or their physicians. And often it can be very stressful for a teenager to know how to deal with this behavior. It's something that makes trained therapists uncomfortable a lot of the time. Generally, we do encourage kids to tell somebody over 18. It doesn't necessarily have to be a parent, but a teacher, someone who can help get that person into treatment. And, you know, it may sound old-fashioned, but if that person's really your friend, they may be mad at the time, but they'll appreciate the help.
I would agree with that. I think it's important for a teen, a young person, not to feel responsible for their friend's behavior, that they have to fix that. Because, as Dr. Good was saying, it's hard for us to help those patients. So one very good resource for schools is the SAP program, which is the Student Assistance Program. And all schools will have that, and it's a group of teachers and administrators who are available to assess if a teen is in trouble and then contact their parents and make appropriate referrals. So the SAP program would be a good source of referral for that child if she sees someone, one of their friends.
But of course, a teenager can't be expected to cure their friends of this problem, but there are some teens who would want to be helpful and to do something and to intervene. Can you think of anything specific? How big is denial a part of this, and can a teen reach out to a friend and at least help them get over the denial phase to the point where they will go seek professional help?
I think my concern, it comes up, is that a lot of these behaviors, I think, happen not during school hours, but more in the evening or the early hours of the morning when people are up and emailing people on the internet, or they just broke up with a boyfriend or girlfriend, and they're emailing things to their peers. I mean, I think the best thing they can do at the time is ask that person if they're safe. And if that other person can't tell them that they're safe, they really do need to involve an adult.
I think really, besides involving an adult, is just listen and be a good friend, but they're really not going to help the person fix that problem, and they can't take it upon themselves to fix it themselves.
Yeah. Ed's calling from State College. You've been very patient there, waiting for us. Ed, we've got you on the air now.
Yes, thanks for taking my question. I was just wondering what kind of treatments you advise, or what kinds of things do you do to try to stop the behavior, you know, aside from drug treatments or whatever. What do you recommend the kids do to substitute for this activity?
Well, treatment would usually be a combination of different types of therapy. So there's individual therapy, there's something called cognitive behavioral therapy. A common form of therapy is called dialectical behavioral therapy, or DBT, which talks about alternative coping mechanisms. And then we do use psychiatric medications, and psychiatric medications can be useful to treat the underlying disorders such as depression and anxiety. But the psychiatric medications alone are not going to do it. Probably the basis of treatment would be therapy.
And Dr. Good, you have what do you have in your toolkit beyond that, which is already mentioned?
Well, as a psychiatrist, I want to get away from only talking about medication. But I think some of the simplest thing we do are simply finding replacement behaviors, things like listening to music, doing something else with your hands. I have some patients who started knitting, you know, anything they can do. The other things you want to do, and this is something family members can help with too, is removing some of the stimulus, meaning that if your child's a cutter, you know, maybe you don't have a bunch of disposable razors in the bathroom, meaning if that your daughter wants to shave her legs, she comes to you, asks for the razor. So keeping again, people will use a variety of things to self-injure, and particularly with the teenager, you can't keep everything out of their hands. It's not like you can toddler-proof. But I think removing some of those, the availability of some of the implements or the stimuli is really important. And I think regulating sleep is very important as well. Again, a lot of the adolescents I've seen with these behaviors are often up very late at night, and sleep disturbance is also a symptom of depression and anxiety.
Final thing would be modification and supervision of the internet, because there are lots of pro-cutting websites, and I think that parents should know where their kids are in the internet and help supervise that.
Interesting. Thank you. And thanks for your call, Ed. We appreciate that. Now, we've been talking mostly about girls, but we know there are boys who do this. So what can you tell us about gender differences?
Again, if there is a boy who does cut, I think many of their symptoms aren't that different from a teenage female or an adult female who cuts, meaning that they're often dealing with a mood or anxiety disorder and eating disorders as well. We don't want to forget that young men also suffer from those.
Right. We have seen males with eating disorders who cut. Also significant substance abuse disorders. So they might be drinking and using other drugs, which as a form of coping, and then when they're intoxicated, they cut or they harm themselves in some way.
Yeah, so you often see like a combination of a variety of impulse control issues, gambling, binging, purging, self-induced vomiting. Which the caller that called in and talked about being sort of a psychologist and treating people with very severe self-harm behaviors sort of have to put out the largest fire first, meaning that you really focus on safety and then address the cutting as it becomes appropriate time in the therapy.
Is there a connection between self-harm and childhood trauma or abuse? Children who have been exposed to injuries and abuse, and not necessarily cutting or burning, but have had some damage to their bodies inflicted within their families. Does that connect in any way to them seeing that as a way to cope?
There is certainly a connection between childhood abuse, and that can be physical abuse, and particularly childhood sexual abuse, and self-harm. But it is important to remember that not all patients who self-harm have been abused, and not all patients who've been abused self-harm. But there is an association.
Yeah, I'm not sure if the type of abuse itself is in any way correlated. What you were talking about, it sounded a little bit like if someone was physically bruised or abused, does that make them more likely to inflict those things on themselves? I think what we look for when people are cutting, some of the questions I ask are, do you feel it at the time? Some people actually like the pain, it makes them feel real. Other people will say that they don't feel it at the time, and that makes us more concerned about like dissociative phenomena, meaning that somebody feels outside of their self at the time. And dissociative phenomena are, again, more common in people with post-traumatic stress disorder or borderline personality disorder.
Now, earlier, Princess Diana was mentioned. Apparently, she had admitted to intentionally cutting her arms and legs and to throwing herself down a flight of stairs. I guess that's public somewhere. Our crack researchers have, tracked it down. And Angelina Jolie and Christina Ricci did too. Because they were celebrities and this kind of thing has been somewhat public, we talked about today's adolescents knowing about that, maybe mimicking that behavior, but has it caused some people to go into their backgrounds, as we're prone to do with celebrities, and find out what was going on? Have we learned anything from those more public situations?
Well, I know that Princess Diana also had bulimia, and that's been well documented. And clearly we see an association between eating disorders, and particularly bulimia nervosa, with impulse control problems in cutting. That would be the extent of my knowledge.
Well, as far as Angelina Jolie, I don't know about her personally, but as far as in the movie Girl Interrupted, which was actually filmed in part of the Harrisburg State Hospital, she does cut in that movie, and in fact portrays, I think she won an Oscar for that too. Yeah, she portrays a woman who is seriously emotionally disturbed. So I think although cutting was part of that, it shows overall that she was having a lot of difficulties, and I don't think it glamorized the cutting in any way. So I think that type of portrayal was very realistic, and I think doesn't glamorize it.
Let's take a call now. We have Wayne calling from State College. Thanks for being a part of our program tonight. You're on the air.
Thank you. Well, I'm someone who has suffered from self-mutilation for about 10 years now. I'm 27. I started in high school, and I found that for a couple of years I was able to mostly keep myself away from it by self-medicating with things like painkillers. And I was wondering what the panel had to say about the correlation between the endorphin rush from cutting and an opiate effect from something like a Percocet or a Vicodin, because I'm going to therapy now to stop myself from self-medicating, but I found that since I am not taking those types of things anymore, that I put some rubber bands on my wrist to snap myself, and I gave them to my therapist today, and I was just wondering what the correlation might be.
Wayne, before we jump into that, if you would stay with us on the air, if you wouldn't mind, we might have a couple of follow-up questions, but let's first turn to our guests.
Well, there is an association between cutting and endogenous opiates, or they're called endorphins, where the idea is that cutting will have your body release those to cope with the pain from a physiological point of view, and then that can become very habituating. So that in some ways that would be like taking opiates. The issue with the rubber band is rather controversial. That has been used as a treatment where you snap the rubber band to feel the pain, but you're not injuring yourself. Some people view that positively as a form of treatment, but others view that as, again, another type of self-harm and trying to find other more adaptive coping mechanisms that you were describing, whether it's art, music, or knitting or whatever, would be a better tack. So there is some controversy about that. Clearly, seeing a therapist and being in treatment on a consistent basis is probably one of those valuable things that you could do.
Dr. Good, thoughts for Wayne?
Well, certainly we do know that there are reward centers in the brain. And again, although we talked about cutting have an addictive nature to it, again, I think if people are talking about self-medicating to cover up this behavior, it's usually not the behavior itself, but rather as well a symptom of underlying depression, anxiety. So again, if you're looking at treatments or medications, again, you want to target the core disorder.
Wayne, just getting back to you, how old were you when you started? You said you were 27 now?
Yeah, I started late 16, early 17. I started with big rubber bands. I would actually snap them to the point that I would break blood vessels, so it was rough.
So you've been coping with this for quite a while. Have you been able to lead the rest of your life pretty much as someone who was 16, 17 at the time and for a decade would have, or is it greatly interfered with what you might otherwise have been doing?
Actually, I do a very good job of putting on a public face. People who know me have no idea that there's that side to me because all through childhood I was taught that you don't let anyone know that there's a problem. You keep a face on, and so I've learned to act very well. So that's something I'm also dealing with through therapy, is learning to express myself in different ways and not internalize things the way that I do to the point that I might.
And did you refer yourself for therapy, or did someone say you've got to go do this?
No, I actually sought it myself. It took quite a while because I don't have health insurance, but I finally found a great service, and it's been rough, but it's been helpful.
Wayne, good luck and thanks for calling.
Thanks.
We're going to put a caller on now who wishes to remain anonymous, so welcome to our program, and tell us what you'd like to ask or say to us.
Hi, I'm wondering, I'm actually undecided right now, a student at Penn State, and I'm thinking about psychology. If I were to help somebody, I'm thinking, what would you do if they're under 18 and they need help, but culturally their parents don't even believe in psychiatric problems? So they don't even believe in it, so they don't want to give the kid treatment. I mean, I really want to help the person, and what would I have to do then?
And is this a situation where the young person you think would like to get treatment or be amenable to it?
Well, even if they want to, like they're under 18, I'm thinking if I were to help somebody, like even if they didn't come to me, if I'm a psychiatrist, I'm like, how do you help somebody if their parents don't even believe in it and they're under 18? At the end, their parents have to say so to their treatment.
Yeah, well, that's a good real life and everyday kind of question about medical care. I know we have lots of students who are afraid to go to the emergency room for a problem because they know their parents are going to see the bill or hear about it, and so they just don't go. What do you advise?
Well, certainly in Pennsylvania, adolescents have a right to consent to be seen. So there's law in Pennsylvania. Now that doesn't get past the whole this is going to get billed to your insurance and your parents are going to know about it issue. I think the other thing we want to make clear too is although we're focusing on getting help from a physician or psychiatrist, there are a lot of natural helpers in the community. And when it comes to psychiatry in general, some people feel more comfortable talking about their depression or anxiety with their counselor at school or that would be someone who would be available to them outside of insurance. Also with a religious counselor, someone of a similar faith and background.
So I would agree. I think a school counselor would be very valuable, or a minister or priest, rabbi, depending on their faith. There are various hotlines that people can call, but also their family physician or pediatrician. So they might be able to help them, or help them with the family and make an appropriate referral. So most people would have a family doctor or a pediatrician they could go to.
And even go to them and say, look, can you just give me a little leeway here and not get my parents involved at this time? Don't send a bill to my house. And certainly if it's someone who's at a university, come into the health service, come into the mental health service that's there, and they're very much in tune with this kind of issue and phenomenon and help to work through it. We have people on the line who are watching and email, and we are out of time. So it's been a great discussion, and I want to remind all of our viewers and listeners that tonight's program will be stored in an electronic archive that can be accessed through WPSU.org. This site also links to online resources for tonight's topic. I want to thank our guests, Dr. Richard Levine of Penn State's Hershey Medical Center and Dr. Candace Good of SUNBRIDGE Health in State College. We hope to see you back here again on Tuesday, January 22nd. We'll remind you as the time gets closer. We'll be talking with the CEO of U.S. Steel Corporation and the Vice President of Penn State's Office of Development about how they spend their downtime. It promises to be an interesting hour. To the Best of My Knowledge is a production of Penn State Public Broadcasting. And for all of us here at WPSU, I'm Graham Spanier. Good night.
Presentation of To the Best of My Knowledge on WPSU is made possible in part by support from the Penn State Alumni Association, informing, involving, and inspiring Penn State alumni and students through its publications, programs, and events. On the web at alumni.psu.edu. Additional support comes from the members of WPSU.
A copy of the program you've just seen can be purchased through Penn State Media Sales at mediasales.psu.edu or by calling 800-770-2111.